Whenever you perform a cross-sectional study, selection bias can be present in many ways. Non-response bias occurs when respondents are systematically different from non-responders, so some groups might be underrepresented just because they chose not to participate. Bias can also be related to sampling problems. For example, a cross-sectional study might overrepresent exposure that have sublethal effects. This is called survivors or prevalent cases bias. And this can be a problem in studies of asymptomatic conditions or with long latency periods. There are other cases in which people who volunteer for a study are not likely to be representative of the general population, or samples of workers usually exhibit lower overall death rates than the general population. And there are also cases in which a non random or convenience sample is used for the study, and meaning that the researchers take whatever individuals happen to be easiest to access as participants in the study. In general, biased sampling implies that some subjects have a higher probability of being included in the sample. In non-biased sampling, the sampling fraction is equal for everyone in the reference or target population. Selection bias occurs in cross-sectional studies when a convenience sample, as opposed to a probability sample, is employed. For example, smoking is a cause of emphysema, but people with emphysema who also smoke have shorter survival than people who don't smoke. Here's what this looks like schematically. You perform a cross-sectional study, and performers who have also emphysema are going to be relatively undersampled because of their survival disadvantage. The final result is an underestimate of the association between smoking and emphysema. Selection bias can occur in a case control study if controls are more or less likely to be selected if they have the exposure. Ideally, controls should be a non-biased sample of the population base from which cases were selected from. Sometimes a good selection of cases is more important than a case selection. This is a very famous case control study with a huge selection bias that assessed the association between coffee drinking and pancreatic cancer. The study concluded that coffee accounted for a substantial proportion of pancreatic cancer cases in the United States. However, subsequent studies failed to confirm this association. So, what did go wrong and why? Controls in the study were selected from a group of patients hospitalized by the same physicians who diagnosed and hospitalized the cases. The idea was to make the selection process of cases and controls similar. However, as the exposure factor was coffee drinking, it turned out that patients seen by the physicians who diagnosed pancreatic cancer often had GI disorders and were advised not to drink coffee. This led to the selection of controls with a higher prevalence of GI disorders, and these controls had an unusual low odds of coffee intake. Controls in the study had an unusual low odds of coffee intake. Then B in the 2 by 2 table was small and biased the odds ratio away from the null hypothesis, which is the same as saying that the odds ratio was overestimated and led to a spurious positive association between coffee intake and pancreatic cancer. Gold in 1985 instead used a population-based controls as obtained from random digit dialing in the community. When doing so, the odds ratio was now roughly half what the first study found, and it was also compatible with a result due by chance. We have seen this study before. A case control study was conducted to assess the development of toxic shock syndrome during menstruation. Cases were age matched with controls selected from among each patient's friends and neighbors. Friends controls produced a lower odds ratio because they were more likely to have used tampons than the neighborhood controls. If cases and controls share similar exposures, such as friends controls, the odds ratio will be biased towards the one. Another example that reflects a bad selection of hospital controls. This hypothetical case control study assessed the association between smoking and COPD. Controls were selected from the same hospital with other lung diseases, and the authors found a weak association between smoking and COPD. So, what was the problem with this study? The thing is that smoking causes many diseases, resulting in higher hospitalization rate of smokers. Hospital controls do not represent the prevalence of exposure in the source population from which the cases of COPD were identified. A key question about selection bias in cohort studies is whether, aside from the exposure status, were the exposed and non-exposed groups comparable. So, a bias due to a non-representative non-exposed group can occur. For example, using the general population as comparison group for an occupational cohort study. There might be other bias related with non-response. For example, if non-response is linked to exposure status, for example, smokers being less likely to respond in a study about smoking and lung cancer. And there's also bias related with attrition, which is withdrawals and losses to follow up that results in risk for disease in the exposed and the non-exposed groups that are different in the final sample than in the original cohort that was enrolled. The health worker effect is a form of selection bias in studies of occupational diseases. The employed workforce, mostly healthy, generally has lower rates of mortality and disease than the general population, and this is perhaps because people that are chronically ill are systematically excluded from the workforce, anyways. A systematic review of prospective studies on the association between smoking and the incidence of Alzheimer and dementia found that smoking was harmful in younger subjects and appeared protective in studies with oldest people. It was possible that cigarette smoking was more harmful at younger ages and beneficial at older ages. However, it's more likely that smoking appeared beneficial at older ages just because of selection bias. Losses to follow up are a serious problem in AIDS studies. Consider a cohort study looking at the progression to AIDS between injection drug users and homosexual men. In a cohort study like this, all the ingredients are ready for selection bias. Getting sick is a reason for being lost to follow up. You just don't feel well enough to come back for study visits. Therefore, people who are lost to follow up have a different AIDS incidence than those that remain in the study. This is called informative censoring. Assume also that injection drug users are more likely to become lost to follow up because of less social support. Therefore, the frequency of informative censoring differs between the IDU and the homosexual men groups, being more common in the IDU group. The result of all this is selection bias. There is an underestimation of the incidence of AIDS among IDU people relative to homosexual men. Selection bias in RCTs can occur during the randomization or during the follow-up after randomization. During randomization, there might be a subversion of the randomization sequence. In the follow-up, the results can be biased due to losses to follow-up or because of protocol violations. The best way to manage selection bias is to prevent and avoid them. In cross-sectional studies, we should strive for high response percentages and be aware of how exposure can affect disease survival. In case control studies, it's recommended to follow the study-based principle and be precise with the case definition. In cohort studies, exposure and non-exposure groups should be identical but for the exposure status. In retrospective cohort studies, the selection of exposed and non-exposed people should be made without knowledge of the outcome. And finally, in RCTs, randomization and allocation concealment and avoiding losses to follow up are good strategies to prevent selection bias. The second big type of bias in research is information bias, which occurs when the information collected about or from study participants is not completely valid. It's also known as misclassification bias or measurement bias, and it distorts the true strength of the association. Misclassification is the immediate result of information bias. Exposure misclassification occurs when exposed people are incorrectly classified as non-exposed or vice versa. Disease misclassification is when people with the disease are incorrectly classified as not having the disease or vice versa. There are two types of misclassification. Non-differential misclassification is random. Errors in classification are about the same in the two groups, and any true differences between the groups are minimized. Misclassification does not differ between cases and non-cases, and it generally leads to a dilution of the effect. Differential misclassification is non-random. If information is better in one group than in other, the association might be over or underestimated. In any case, non-differential misclassification is always better than differential misclassification. Non-differential misclassification might be related with difficulties remembering exposures or recording and coding errors in databases, using surrogate measures of exposure, or non-specific or broad definitions of exposure or outcome that are equally mistaken in both groups. Examples of differential misclassification include differences in remembering exposures in the two groups, interviewer or recorder bias, or obtaining more accurate information in one of the groups. Recall bias is a very important type of bias in case control studies or when exposure history is obtained retrospectively. It means that cases might be more closely to scrutinize their past history, looking for ways to explain their illness. Controls, not feeling a burden of disease, might less closely examine their past history. So it means that people with diseases might remember exposures differently, more or less accurately than those without the disease. Some causes of differential misclassification include reporting bias, meaning that individuals with more severe diseases have more complete records, a Hawthorne effect, individuals who are aware of being participants of a study behave differently, or placebo effect, which is the expectation that placebo will have an effect. Other sources of differential misclassification include interviewer or observer bias or detection bias, which are systematic differences between groups in how outcomes were assessed. Ways to deal with information bias include blinding, a strict definition of exposure and outcomes, getting accurate data, confirming data, and using procedures to minimize losses to follow up. The main conclusions of this lecture are all sorts of things can go wrong in an EPI study. The two types of errors in EPI studies are random error and bias. 95 confidence intervals and p-values help to deal with random error. There are three types of systematic error: selection bias, information bias, and confounding. And finally, selection bias and information bias are due to flaws in a study design. This is the end of our lecture. Don't forget to complete weekly trivia 8, participate in the forum, and post your questions. There's no assignment this week. Yay! So I'll see you soon. Bye.